Okay, good morning, guys. Today we're going to be starting chapter 20, and that is the blood vessels. So we talked in the past about the pump, the heart that generates the pressure gradient. So we need to create a pressure gradient, a pressure difference. At one side, there is high pressure, more than the destination, so that the blood can flow from the area of a high pressure to an area of a low pressure. So in the aorta, that is the biggest vessel and the closest vessel to the pump, to the heart. So the heart is pumping. We talked about systole. So the ventricles contract and the blood is ejected through the semilunar valves, and the blood is going from the ventricle into the aorta. So the aorta is the first tunnel, the first conduit, the first blood vessel that receives the blood. Who's going to have more pressure than the aorta? If you compare your aorta to all the other blood vessels, do you think anybody's going to have more? You think anybody's going to have more pressure than the aorta? Of course not, because it's the closest to the pump. Immediately, right after the heart, you have the aorta. So nobody's going to have more pressure than that. So the farther away you go from the aorta, do you think the pressure is going to increase or decrease? The pressure is going to decrease. Otherwise, it's not going to move in that direction. So pressure is going to be the highest near the pump, near the heart, and it's going to be the lowest away from the pump. So where is the pressure going to be really the lowest? Is the most lowest. The pressure is going to be where? In your vena cava, because that's where the blood has now returned to the heart. So the blood is the pressure is the highest right when you're leaving the heart, and is the lowest right when you're returning to the heart. Then we have a circle. Then we have a circle. In the middle of that circle, there's another circle. That's the capillary. We're going to talk about that. So blood is going to be entering the tissue capillary to exchange blood with the tissue compartment, and we're going to be uptaking the nitrogenous waste. We're going to be talking about the pressure. So pressure concept is very important. The hemodynamics and the hemostatics, the blood movement and the blood stoppage. We're going to talk about that. And we're going to talk about what kind of pressure we're dealing with. I know we talked about different types of pressure gradient, but what kind of pressure? Do we only have one kind of pressure? Of course not. We have hydrostatic pressure. What's hydrostatic pressure? Hydrostatic pressure is the pressure of the heart, the pump. That's hydrostatic pressure. Is that the only kind of pressure we're dealing with? What's another type of pressure that we're dealing with besides hydrostatic? Do we only deal with pressure of pumping blood? Is the only kind of pressure we're dealing with? What's the other kind of pressure besides another type of pressure that is besides hydrostatic? Hydrostatic pressure is the pressure of squeezing, filtration. When you filtrate, when you pump the blood in the vessels and it gets to the capillaries, and then because the pressure is so high, it gets to leak out. What's the other type of pressure then? How about osmotic pressure? That's not osmotic pressure. Solute. We said that water is very concerned with solute differences. So water is going to be concerned with solute differences. If you have water right in the middle, let's say water is standing where I am right now. To the right of me, there is 500 milliosmoles. To the left of me, there is 100 milliosmoles. Are these two pressures or not? These are two osmotic pressures. One is 500 milliosmol, one is 100 milliosmol. Do you think water is going to move to the 500 milliosmol, or is it going to move to the 100 milliosmol? Raise your hand if you think it's going to go to the 500. Raise your hand if you think it's going to go to the 100. It's going to go to the 500 because water is going to go to an area from low solute to a high solute. It's going to choose the 500 milliosmol to dissolve it over the 100. Maybe if you had a 100 and a 10, it's going to go to the 100. But water is always going to an area of high, a very high solute concentration. The milliosmol is the measurement of the solute, the osmolarity. It's the measurement of the entire solute osmolarity. Entire solute osmolarity. So some solute has 500 milliosmoles. There's water there, but there's the concentration sums up to 500. On the other side, with water, it doesn't mean there's no water at all. No, that's the overall fluid osmolarity comes out to 100. Are we clear? Okay. So now, the key concepts that we have to go over . Okay, so there's a bunch of key concepts that we have to first understand. We must understand that pressure is the main driving force of fluid movement. We go from an area of a high pressure to an area of a low pressure. There is no way around that. You will never have movement from low pressure to high pressure. And we said that this is all for fluids. So fluids, and we have two kinds of fluids. We have two kinds of fluid. We have liquid fluid, like the blood. The blood is an example of a liquid fluid. And we have gaseous fluid, and that's an example of that is air. So the blood, that's the cardiovascular system, and air, that is the respiratory system. You're going to see that again when we do the respiratory system. But for now, we're going to stick with this, with blood. So we're moving from an area of a high pressure to an area of a low pressure. And we said an area of a high pressure is an area that is closest to the heart. An area that is closest to the heart. So this area has the highest pressure because it's closest to the pump. And this here has the lowest pressure because it's farther away from the pump. So now when you look at your pressure, we said we have two kinds of pressure. We have two kinds of pressure. We have pressure that is hydrostatic pressure. Hydrostatic pressure. In addition to hydrostatic pressure, what other pressure do you have? Osmotic pressure. Excellent. We have osmotic pressure. And we said that hydrostatic pressure is filtration pressure. This is filtration pressure, and osmotic pressure is the pressure of solutes that this is the milliosmoles that's gonna tempt the water to come from the ocean. Either way, the more pressure there is, fluid is going to be moving from an area of high pressure to an area of low pressure. If you have area A and area B, area A has low milliosmoles and B has high milliosmoles, the water is going to go from an area of high to an area of low. While hydrostatic pressure, and you're going to have hydrostatic pressure that is millimeters of mercury, the units of millimeters of mercury. If you have an area of A, that's 150 millimeters of mercury. You're gonna move to area B, that is 50 millimeters of mercury. Okay, so you must understand that because you will see that at the capillary. You're gonna come back. When you look at the capillary, how is the fluid moving out is gonna factor into this equation. So now let us look at what are these blood vessels. So you know, remember we said in anatomy and physiology, the structure has to match the function. So if you are the aorta right here, so the aorta is right here where the pressure is the highest. And then you have the vena cava here. This one is dealing with so much pressure. The aorta is dealing with so much pressure. The vena cava is dealing with little pressure. Do you think they are as thick? If you take a histological image, when we look in the lab today, do you think that an artery is going to be as thick as a vein? Who's going to be thicker? Who's going to be less thick? It's pretty obvious if you can tell one is dealing with a lot of pressure, one is dealing with a little pressure. Which one has thickest layer? Which one has a thinner layer? Exactly. So now that brings us into the 3 layers of the blood vessel. The blood vessel has 3 layers. 1, 2, and lastly 3. The outermost layer is known as, all of them are known as the tunics. Tunica on the outside, tunica in the middle, and then tunica on the innermost layer. On the outside is known as the tunica externa. It's really on the outside. The tunica externa, also known as the tunica maxima. On the middle is known as the tunica media. And on the innermost, that's known as the tunica minima, or the tunica intima, because it is so intimate with the blood, the tunica intima. Those are the 3 layers of the blood vessel. Whether you are an artery, whether you are a vein, you gotta have those 3 layers. But those 3 layers histologically are different. The most important one is the middle layer. So if one blood vessel is much thicker, so if the aorta is thicker than the vein, the vena cava, why is that? It's because the tunica media has more smooth muscle. It's thicker and more rich. Its middle layer is the thickest. The outer layer is fiber. The outer layer is fibers. Okay? That's the fibrous, connective, tough tissue. Fibrous, connective, tough tissue. While the middle layer, that's smooth muscle tissue. And the tunica intima, that's the one that's intimate with the blood. So that intimate layer is so important because that intimate layer with the blood, that's the one where your platelet is going to stick. Your platelets are going to be sticking to your tunica intima. So your tunica intima is the one that's going to be recruiting blood vessels, white blood cells. The tunica intima is going to say, we are injured. We need white blood cells to come and fight the bacteria that is secreting toxin, that is injuring us, that's causing an injury. We're going to need platelets, band-aids, platelets, to come and stick to the tunica minimum or the tunica intima. So that's the layer that your blood is intimate and dealing with constantly. Your blood does not deal with the maximum because it's on the outer cover. That's like the outer layer, a fibrous connective layer protecting the a case that covers the wire from outside. And the media is the one that is rich in smooth muscle because the tunica media is responsible for choking and constriction and relaxation. So each layer, you gotta know the three, you gotta know which one is where, and what's the significance. What's the significance of the outer fibrous layer? What's the significance of the middle layer with the smooth muscle that constrict and dilate? And what's the tunica minimal or tunica intima that's responsible for the recruitment of platelets and recruitment of these white blood cells. Are we clear? Okay, so now we're gonna move on. We're gonna now move on to a new concept. You have to understand that veins and arteries, we used to assume in the past mistakenly that arteries always carry oxygen-rich blood and veins always carry oxygen-poor blood. That is not true. Artery means it's carrying blood away from the heart. Veins means it's carrying blood towards the heart. Well, you can carry good blood towards the heart, like the blood going to the left part that's going to the system. So what kind of arteries, what kind of veins are those? Those are coming from the lungs with the pulmonary veins. You can have bad blood coming back to the heart that's coming from the vena cava. So it can be pumped by your right heart to the lungs. So that's systemic veins. You can have blood that's going away from the heart, that is good blood, like in the aorta going to the system, that is now systemic artery. And going away from the heart to be purified in the lung, dialysis, clean, removing all, and that's going to be known as the artery that is pulmonary artery. So we need to sit down and get those in your mind. Then you need to also understand something, that these veins are like toothpaste. You know, you squeeze the toothpaste is gonna come out. The veins are like that. When you are injured and they call you're bleeding due to, God forbid, gunshot wound, stabbing, long before the ambulance get there and they take you to the hospital and they give you blood, your blood vessels have a reservoir. They have a reservoir. They have a blood bank. They have a blood bank. These are known as the capacitance vessels. These capacitance vessels are the veins. So the veins are massive. They are huge, and all the blood is not flowing through it. It's stagnant. It's stored. It's the storage capacitance storage site. So the blood is in the capacitance vessels. 64% of your blood is in the veins. So when you're bleeding, the veins are gonna now squeeze to rush blood back to your heart and perfuse your tissues until the ambulance get there and you get to replenish the blood that you lost. So you have an ambulance before the ambulance. You have a first aid mechanism, and that's your capacitance vessels. These are the veins. That's a very important concept. Is that clear? Okay. Then we have to also understand that when we get to the capillaries now. So now when we get to the capillaries, let's look at what's happening at the capillaries. So now I have blood coming from the arteries, and my capillaries have two halves. One half approximately. One half dealing with veins that are bringing blood back to the heart, to the right heart, to the right atria, because you have a right heart that's going to pump to the lungs, Okay, so you have, this is the capillary. This is the microcirculation. The microcirculation. You have to understand the microcirculation has two halves. A good half and a bad half. A half that is bringing all the good positive stuff, bringing in the oxygen plus nutrients for metabolism and the hormones, neurotransmitter, all the good stuff. And the other one is taking the bad carbon dioxide and it has all the metabolic waste and toxin. And don't forget that this tissue here, this microcirculation is dealing with who? What am I drawing here in brown? What is that? What am I drawing in brown? Yeah, that's the tissue component. That's the tissue. So what's going to happen here, this is really, really important. So once the blood got here, is the arrow going to point out towards the tissue? Or is it going to go from the tissue into here? Where's the arrow going to point from? Is it going to point from the microcirculation into the tissue, or is it going to point from the tissue into the microcirculation? I'm sorry? Is the arrow going to be pointing toward the tissue, or is it going to be pointing toward the microcirculation? It's going to be pointing toward the tissue, because we want to give tissue oxygen. We want to give tissue nutrient. So the arrow got to point here. So all this stuff is going to be oozing out. All the stuff is going to be coming and oozing out. Well, this movement is going to be from an area of a high pressure, remember? Of a high pressure to an area of a low pressure. So pressure in the tissue has to be low so all the good stuff can come out. It makes a lot of sense because the oxygen is rich here. There's a lot of oxygen here. There's a little oxygen here. The partial pressure for oxygen in the tissue is low. The partial pressure of oxygen in the circulation is high because we just coming from the heart, right? So now oxygen is going to flow out. So what kind of pressure is going to make all this stuff like a toothpaste squeeze out, come out, squeeze out, squeeze out? What's going to make it come out? What kind of pressure is that? Excellent. That's going to be the hydrostatic. That's going to be the hydrostatic pressure. Going to be hydrostatic pressure from the pump, from the heart pumping. That's hydrostatic pressure. Now the tissue took all the oxygen, took all the nutrient, took all the neurotransmitter. You know, you order Uber Eats, you order Papa John's. After you eat, you have garbage. So now you want to send the garbage out. So now the arrow going to be pointing away from the tissue toward the circulation, away from the tissue toward the circulation, away from the tissue toward the circulation, or is it going to be pointing from circulation to the tissue? It's going to be pointing away. So now you see that in the tissue, the partial pressure for carbon dioxide is high or low? Is very high because it's very toxic. And the partial pressure for oxygen is low here or high in the tissue. It's very low because we burned it. Before, when we were coming in, the partial pressure for oxygen is very high and the partial pressure for carbon dioxide is very low because you're just coming from the lung. But now it's the other way around. So now who's going to be making all the metabolic waste ooze back in? It's not a hydrostatic pressure because the tissue is not pressing anything. Is the tissue pressing, squeezing all the stuff out? So what's making all this stuff move? It's got to be some form of pressure. It's got to be some pressure because we already agreed there is never any fluid movement except from an angle from high pressure to low pressure. So what pressure is driving the movement of the waste and carbon dioxide in this direction? I never said there is gas pressure. I said gas fluid move because of some pressure. I already named two pressure in the beginning of the lecture. I named hydrostatic pressure and osmotic pressure. So that's the osmotic pressure. It's really dilute and nasty here. Here by the tissue is really dilute and toxic and nasty. So that's osmotic pressure. So they're all gonna be moving into back into the circulation, and we're gonna flow right back into the heart. Yeah, so these are two pressures working. You have hydrostatic pressure to give you the good stuff, and you have osmotic, because hydrostatic pressure is only dependent on a pump. You gotta have pumping. The tissue doesn't have a pump. So the tissue now relies on osmotic pressure. So the osmotic pressure is gonna return all the nasty stuff by diffusion. Remember, diffusion is more nasty in the tissue than here, so all the nastiness is gonna ooze back in here. So naturally, everything gonna go back. One more thing you need to know. A hydrostatic pressure is more efficient than osmotic pressure because 100% of fluid move out. But when you're utilizing osmotic pressure, it is not 100%. It is only 85%. 85% of the nasty stuff move back here. And 15% lag behind. 15% sediment deposit behind. Well, if it keep on lagging behind, it's gonna kill us. Whose responsibility is it to this 15% that's lagging behind to take it back? Yes, what did you have a question? I cannot hear. So there's different reasons why organ damage happen. Organ damage happen because of reactive oxidative species. Organ damage happen because of trauma. Organ damage happen because of infection. Organ damage happen because of fibrosis. There's many different things. But here, if 85%, if your osmotic pressure is only good enough to push 85%, 15 stay back. If you keep this 15 back, then another 15 is going to stay back, and another 15 is going to stay back, it's going to kill us. There is somebody who is responsible of cleaning up those 15% that stay behind and return it back to the right heart. Whose job is that? Whose job is it? There's a whole system. Kidneys, no. There's a whole green system that's going to be parallel, a green system that's going to be parallel, a green system that's going to be parallel to your venous circulation, and is going to be this green stuff is going to be taking the 15% and say, "Oops, you only took 85, you left behind 15. Don't worry, I got you. I'm a safety and the safety line." That's the what? Lymphatic system. The lymphatic system. So the lymphatic system is going to be bringing back the 15% that stays behind. Are we clear? Is that clear? Okay. Then we move on to in the end of this chapter, you don't just have to memorize your vessels now. You just have to sit down and know. And you know, when it comes to the vessels, students, they get caught up memorizing those little tiny vessels and they leave the big ones. Imagine somebody doesn't know the BQE, doesn't know the Major Deegan Expressway. They don't know the Long Island Expressway, but they know the tiny little street. That doesn't make sense. So whenever you want to know your vessel, you begin with the biggest. You begin with the very big. And nothing for you to stress. I already gave you the exam. You saw today. Did I bring one question that was on the homework? No. So that's how it's going to be for lecture and for lab. But you have to be reviewing a lot. So make sure that when you are learning these blood vessels, you begin with the biggest one. You begin with the aorta, you begin with the pulmonary trunk, then the abdominal aorta, then the iliacs, and then the carotids, and the bifurcations. We will see that now when we look at the figures. So that's something you sit down. You have to sit down, look at them a long time, then you will understand. Okay? So before we go, so we're gonna have we have an axial skeleton and an appendicular skeleton. Remember you did that in AP1. So now we're gonna look at the blood vessels. We're gonna be nourishing the axial skeleton and the appendicular skeleton. Is that clear? Okay. What else? Okay, and then there's this concept of the valve. So, we are very concerned with one-way movement in the body. We said that this is not only in the cardiovascular system, also in the digestive system. You don't want gastric reflux. That's why you have a sphincter. But in the blood vessel, we don't have a sphincter. We have a valve, a one-way valve that allows the passage in one way. So we're going to be learning about varicose veins. We're going to be learning about varicose. Anybody heard of hemorrhoids? Hemorrhoids? Yeah, so hemorrhoids, those are defective valves in your anal canal, in the veins of the anal canal. But the biggest example of valvular destruction in varicose vein is for obese people and occupational hazard, those who stand for a long time, the barber standing all the time, and the cashier standing all the time, the traffic police, the teacher standing all the time, nurses standing all the time. What happens is, in order for blood to move the same way we want it to be in a circle, so you cannot go back in a circle. You have to complete the whole circle. So there's only a valve that's going to prevent backflow. So if you look at the veins, they have valves that are like that. Valves that are going to ensure blood moves in one direction. So that when gravity, gravity from physics is pulling blood down. So now the blood is naturally being pulled down, but the vessel is only opening up. When you are obesity, when your job, occupational hazard, meaning you're standing all the time, pregnancy, these valves get destroyed. When these valves get destroyed, blood now is not only going to move in one up, it's going to start to pool. We're going to have blood pooling. So the blood is going to pool on the bottom. So when the blood pools on the bottom, you're going to have like a lot of damage to these valves, and you can detect it. You can lift up your pants and look at the back of your calf, and you will see those defects, meaning that blood is pulling down. Okay? And then another issue is age, old age. I mean, even if you never got pregnant, never had occupational therapy, never been obese, when you get really old, you will end up with that. Blood pressure, we talked in the last lecture, systolic, diastolic. For a young person, the normal blood pressure is 120/80. For a 70 senior citizen, the normal blood pressure is 145 over 90. That's normal. Why? That is vein. veins. So because of that, we make pooling, but that will not affect the blood pressure. What affect the blood pressure is the blood vessels, atherosclerosis, 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 which is different from there's atherosclerosis, that's the hardening. Sclerosis means hardening. Hardening of blood vessels. And we have arteriosclerosis. Arteriosclerosis, meaning that the artery is hardened. But athero, it means that there is fat plaque. It means that there is fat plaque build up. There is fat plaque build up. Fat plaque build up in between the tunica media and the tunica interna. So you have the tunica maxima, tunica media, tunica interna. You have plaque building up here and making a bulge. So now the blood is not moving, it's blocking, occluding the passage of blood flow. So that's going to end up with a hardening. It's going to make your blood vessels harden and less distensible. You know your blood vessels, they need to be malleable. They need to be able to expand and relax. Vasoconstrict, elastic. They need to be elastic and distensible. So arteriosclerosis, they become stiff and hardened, so they no longer going to be able to extend and relax, and that's what's going to cause the blood pressure to be higher as we age because our blood vessels got hardened. So that's the reason why it's normal for elderly people to develop a normal high resting heart rate. So if you were running around and you go to the emergency room, they take your blood pressure is high, that's normal because that's not resting. Resting is different. So why is our blood pressure when we get older, why is it normal for it to be high?
That's my question.
No, you were playing on the phone, I explained it already.
No, because I'm making some,
Okay, so what's the answer?
because
Can somebody tell me the answer? So as we get older, what happens? So the arteries get less distensible, less elastic, which is known as arteriosclerosis. And I'm also going to ask you on the exam, there's a question there, what's the difference between atherosclerosis and arteriosclerosis? So you can be hardened because of a fat plaque, that's atherosclerosis. But you can get hardened without a fat plaque because of reactive oxidative species, because of damage, because of old age. That's known as arteriosclerosis. So one of the reasons we can have arteriosclerosis is because atherosclerosis. But not every arteriosclerosis is caused by. One of the ways that's going to make arteriosclerosis is atherosclerosis. So atherosclerosis can lead to arteriosclerosis. But that doesn't mean there is no other things that can cause arteriosclerosis. So arteriosclerosis when the artery is very stiff and thick. Is that clear? Are we clear?
Can the artery be stiff and thick and also have fat buildup?
This is the terminal thing. So all bad things lead to that. This doesn't lead to that. That leads to this. So you don't get arteriosclerosis then, no. You get the fat first because you eat the unhealthy, the big beef burger with mayonnaise and cheese, and then that leads to the arteriosclerosis. Where does that happen? The arteriosclerosis, where does it happen? The arteriosclerosis, where does it happen? Which artery? Definitely not the ear. Definitely not the ear. Yeah. I cannot hear that. I said last week, the crown. The coronary artery. Yeah, the coronary. Yeah, the coronary, right? Coronary artery. Okay, so now we're talking about varicose vein. What are the causes of varicose vein? Why does somebody have blood pooling in varicose vein? Because the damage of the valves. So what leads to the damage of the valves? What are the reasons that lead to the damage of the valve? Occupational hazards, such as stand job that make you stand for a long time, such as
Construction.
the barber guy.
Barber,
Yeah, that one is that crazy. That one he doesn't get a rate. I'm amazing.
Waiters.
Yeah. Yeah. Yeah, I mean, you know about like the barber. You guys are unbelievably bad. They're dangerous. Standing for too long. And by the way, and they stand and they're moving too. They're standing and they're moving. It's dangerous. And another, yes.
So does the precious have to be held in?
It's a business. It's just something, it's little, just to make you buy it, but then really not. It's something, don't exhaust yourself on it, so try to be moderate. Don't have, like me, teaching in many schools, lecturing many hours, that's not good.
So what do you do to help yourself?
Yeah.
Just accept that it's not
I
good.
know, I'm good.
So
Yeah.
would it be good to elevate your feet at home?
Huh?
Would it be good to elevate your feet? Would it be good to elevate your feet?
Will I?
I'm just saying, would that help elevating your feet?
Yeah, it will help, but the damage is beyond salvage. The damage is gonna be beyond salvage. Damage beyond salvage. This is not working. Damage beyond salvage. So if damage is beyond salvage, then they're not coming back from that. But it's okay. I don't think one more year, I'm retired. I'm done. Okay, so what else is there? We talked about, another more very important thing. So now we already established your blood vessels. They are not tube, they're not plastic. They are responsive. They can constrict. They can dilate. So now your nervous system is going to be able to discriminate. You know, you see, discrimination is bad when it's sociology. Discrimination based on race, discrimination based on gender, all of that is bad. But in science, actually, you have to do a neurological exam to see if the patient can discriminate. Were they poked with a pin object or were they poked with a rough object? Okay. Yeah, that kind of discrimination is sensory discrimination. It's good. Also, your nervous system has to have the ability to discriminate. Who should I give more blood to? My skeletal muscle because I'm running a marathon, or my abdomen and my intestine because I'm sitting on an armchair and I'm sitting on a recliner on a Saturday night eating, lunch. So your mind has to know that, has to know how to shunt blood. That's exactly what's happening. So we're going to be studying that your nervous system is going to be, when you're running a marathon, squeeze, constrict the blood that's going to your intestine because you're not utilizing the digestive system. And it's gonna dilate the blood vessels going to your thighs because you need that for running. So that one is very important for you to understand that blood is not just flowing at the same rate. No, some places it depends on what you're doing. If you're eating, blood is gonna be going to your digestive system and nothing is going to your legs and thighs. So your heart rate is going to be the same. But once it, like for example, your salary, you get paid $3,000 a month. One time you spend more on Costco and this, the next time you spend more on this and that. So you get paid the same amount of blood, 5.5 liters every minute gets pumped. But where it's going, depending your mind, you make discrimination. Who needs more blood is gonna get the blood. You take an exam, more blood gonna go to your brain. You're running a marathon, more blood is gonna go to your thighs. Is that clear? Okay. Okay, so let's start the slides, and if we get to something that needs explanation, we will get to that. Okay. Okay. Okay, so now I sat down, I relaxed my bowels. Okay, guys. Okay. We discussed that arteries carry blood away from the heart. It could be good blood, it could be bad blood, but always away from the heart. Veins carry blood back to the heart. And capillaries is where they fuse next to the tissue so the exchange can take place. So that shows you, remember the tunics? If you now, this is a very nice figure because it shows us all three. It shows us our artery, and the artery has, which one is the tunica externa? That's the one on the outside. You see how thick it is? It's a fibrous tissue. Then on the middle, you have the tunica media. Then on the inside, you have the tunica interna that's going to be dealing with the blood, and the platelets are going to be attached to it and all of that. Are we clear? Okay, the walls of the arteries and veins have three layers, tunics. Tunica interna, other books call it tunica intima, tunica media, tunica externa, also known as tunica maxima. The tunica interna or the tunica intima is going to line the blood vessels and paste them from the inside. It's like a pasting. It's like an inner layer. Is the endothelium that has what kind of tissue? You know, we talked about the tissues back in AMP1, and that's where you have simple squamous epithelium overlying the basement membrane, and there's you know, the simple squamous. These are the cells that like a sunny side egg, like an egg sunny side up. So their nucleus is facing up, and they act as selectively permeable barriers, and they secrete chemicals that stimulate dilation or constriction of the blood vessel. So the endothelium is going to repel blood vessels, is going to be secreting substance that's going to repel and push away all the useless or all the platelets. But when there is an injury, it's going to be secreting another different subset of cytokines that's going to cause the attachment of these platelets. Are we clear? The tunica media. The tunica media is the middle layer. It has, you see, the smooth muscle, the collagen, and the elastic tissue. The tunica externa is the outermost layer. It has loose connective tissue, and it provides the passage for the small veins. And please remember this, the vasa vasorum. What's the vasa vasorum? The vasa vasorum are small vessels that supply blood to the outer part of the large vessel. You will find that question on the homework and on the exam. What's the vasa vasorum? It's the circulation of small vessels that nourish and supply blood to the outer, middle, or inner tunic. The outer tunic, yeah, very good. So that shows you the histology of the blood vessels. And you see the venial is the smallest compared to the medium and a large veins. And you see that, and when we look at the arteries, we have three different classes of arteries. We have conducting arteries, and we have distributing arteries, and we have these arterioles. The conducting arteries are the highway. You're on the highway. The exit ramp, that's the distributing medium artery. The arteriole is a little street that can hit your home. That clear? So this distributing arteries, that's like the aorta. That's the very big highway. That's the major beacon. That's the DQE. That's the APR. That's very big. And then you have the distributing, and that's like the ramp that you take into the exit ramp. And then the arteriole is the one that's the street that's going to get you to where the school is. So you see conducting, these are the biggest, so they're going to have the thickest layer. It makes a lot of sense because they are closest to the pump. They deal with a lot of blood coming out from the pump, hitting the walls. Imagine the aorta was thin. All this blood rushing, gushing out, hitting the wall of the aorta is going to rupture, break. So that's why the aorta is really thick. So arteries are classified by size. There are distributing muscular or medium arteries, and they distribute blood to specific organs. There is brachial, renal, and splenic arteries. Those are the exit ramps. Those are the middle ones. So an example would be, you got to know which ones are your conducting arteries. And we say that's the aorta, the common carotid, the subclavian, and the pulmonary trunk, and the common iliac arteries. So a question on the exam would be, which of the following is not a conducting artery? Aorta, common carotid, subclavian, pulmonary trunk, or brachial? You say brachial. So now, what are the distributing, the exit ramp? The ones that are middle size, these are the brachial, femoral, renal, splenic. A question on the exam would be, which of the following is a conducting artery and not a distributing artery? Brachial, femoral, renal, splenic, or subclavian? And the answer would be the subclavian. And lastly, you have the arterioles. These are the ones that are connected to the capillaries. Meta-arterioles. These meta-arterioles, in some places, these are short vessels that link the arterioles to the capillary. So they are even smaller than the arterioles, and they connect the arterioles to the capillary. So there you go. So now, if this arrow was not there, you should tell me what the arrow should go to. So should the arrow go from red into blue and back to the heart, or from blue into red and back to the heart? Red to blue. So that shows you, and you know we have sphincter. So the sphincter, we have it in our stomach so that the blood does not, so that the acid does not reflux back into the esophagus and burn, scratching the esophagus. We also have those in the blood vessels because we want to make sure, we want to give a lot of blood to the skeletal muscle, relax the sphincter so blood can go to skeletal muscle while you're running a marathon, and squeeze the sphincter that's leading blood into the intestine because you don't need that. And the opposite, you need more blood to the intestine, relax the sphincter, blood is going to go to the intestine and constrict the sphincter in order for blood to go, in order for blood to go to the proper place. So these are the meta arterioles. They link the arterioles to the capillaries. What's an aneurysm? An aneurysm is a balloon. An aneurysm is a balloon. So an aneurysm is a balloon. If blood is flowing and then blood is hitting the wall, so hard, what's gonna happen is a balloon is gonna form. And blood now is gonna start accumulating in this balloon here. Then it's gonna rupture and leak out. That's the aneurysm. So it's like a sac that's gonna form due to the high blood pressure hitting the wall and causing a defect and leaking, accumulating between the tunic. Remember we said the tunic between them, you can have a lot of fat build up. Now you can have even blood build up. When the fat build up, we call it atherosclerosis. When the blood build up, we call it aneurysm. It happened a lot in the brain, called brain aneurysm. It's vacuum, but we can get rid of this. Oh wow. I didn't need to bring markers. Okay. We talked about the battery reflex, that these blood vessels, they gotta have sensors on them. How many different sensors do we have? We have sensors for blood pressure, that blood is hitting the walls too hard, we gotta have an aneurysm, we have high blood pressure, so we gotta send the glossopharyngeal nerve is gonna say that there's high blood pressure, then the vagus nerve is gonna say the blood pressure is gonna go down. What is the pressure sensors the only type of sensors we have on the blood vessel? What are the other types of sensors we have on the blood vessel? Stretch are the same thing as pressure, but they're sensing the pressure of the stretch. What are the other types of sensors that we have? What are the other types of sensors we have on the blood vessel besides stretch? How about tasting? Tasting the blood. Is it too much carbon dioxide on it? Is it too little carbon dioxide? Is it too much oxygen? Chemoreceptors. So we need those two. So we need to report to the brain, oh my God, the carbon dioxide too much. So the brain is going to send a message to the lung, hyperventilate. Send out all the carbon dioxide, otherwise it's going to build up in our blood, making acidosis. So we need two kinds of sensors. Sensor for stretch and a sensor for chemistry, chemoreceptor. Baroreceptors. What kind of receptors are they? Stretch or chemicals? So stretch receptors. You need to know them and where they're found. In the internal carotid artery, they monitor blood pressure. Chemoreceptors. They taste and stabilize carbon dioxide, oxygen, and pH. So these are the carotid bodies. They have chemoreceptors. They are oval bodies near the branch of the common carotid. They monitor the blood chemistry and they transmit signals through glossopharyngeal nerve to the brainstem respiratory centers. Aortic bodies. These are chemoreceptors, and they are 1 to 3 bodies in the walls of the aortic arch. So you have to understand that the carotid bodies and the aortic bodies, both of them are chemoreceptors. One is found in the branch of the common carotid, and then the other one is found in the aortic arch. And the same structure and function as the carotid bodies, but their innervation is by the vagus nerve. So there we go. This is the carotid body. So the sinus, the carotid sinus has a baroreceptors for blood pressure, while the carotid bodies are chemoreceptors. One is found here and the other one is found in the aortic arch. Capillaries, we discussed the capillaries, and these are exchange vessels. And these are the site where the gases, the nutrients, the waste, and hormones are gonna pass between the blood and the blood vessels. And they call them the business end because there is a lot of exchange that happens at that business end. And they are composed of endothelium and basal lamina, and they are absent or scarce in tendons, ligaments, epithelia, cornea, and in the lens of the eye. So there are three capillary types, distinguished by the ease with which the substances are going to pass through their walls, and there are continuous capillaries, fenestrated capillaries, and sinusoids. Sinusoids are collection sites where blood is going to be accumulating in these sacs. So now let's look at the three types of the capillaries. There are continuous capillaries, and these are the most prevalent on all the tissues. There are endothelial capillaries, and they wrap around the capillaries and they contain the same contractile protein as the muscle. So pericytes are found in your retina. That's why people with high blood sugar, they get blood rupture in their eyes, in their retina, because the sugar is going to accumulate in the pericytes. So the pericytes, these are cells that wrap from the outside around the capillaries, and they have a function of constriction and relaxation. So they can burst, they can explode, they can blow up when there's too much sugar latching on them. And when there's so much diabetes, meaning there's so much sugar that is depositing on the surface of these cells. Are we clear? Fenestrated capillaries, these are kidneys, small intestine. They're found in the kidneys and the small intestine. The organs that require these are organs that require rapid absorption or filtration. Endothelial cells, these are endothelial cells that are riddled with holes called filtration pores. So these filtration pores allow for the passage of the electrolytes, allow for the passage of white blood cells, and allow for the passage of substance. These sinusoids, these are, as we said, irregular blood-filled spaces with large fenestrations. They allow the proteins, albumin, clotting factors, and new blood cells to enter the circulation. So you see that's the pericyte. The pericyte is found around the blood vessel. And you see that these are so you see that's the endothelial cell. You see that's the endothelial cell, and these are two endothelial cells, and between them, these are known as intercellular cleft, interendothelial gap. You see the staple here? That's the staple. This staple is a tight junction. And that's the red blood cell. And that shows you this is a vesicle. The vesicle is going to enter from this side, is going to make its way to the outside here. So we can bring inward. We can inwardly bring in vessels into the middle, and we can take out vessels and send them out from the other side. So you see that the two sides of the endothelium are moving, right or left. Are we clear? Are we clear? These are fenestration pores. that they allow for the exit and the entry of substance. That is important for the well-being of this blood vessel. And that shows you the fenestrated capillary. So fenestrations are holes. These are filtration pores that allow for the passage of substance through them, through these fenestrations. Are we clear? Look at the sinusoids. These are irregularly filled blood sacs, and they are found in the liver as well as the brain. Okay, we discussed that, we can regulate the amount of blood that's flowing into the capillary by looking at the sphincters. These are precapillary sphincters. Those are these are sphincters that are precapillary. So they are before the entry into the capillary. There are also thoroughfare channels. Thoroughfare channels, these are the channels that allow for the exit of the blood into the veins. See, these are the thoroughfare channels that allow for the passage of the blood through the tunnels that are going to lead it back into the right heart. So the veins, they have, you remember we said that who are the capacitance vessels? These are your veins. They have thin walls because they are very far away. They don't deal with a lot of pressure. And they are subject to relatively low blood pressure. That's about 10 millimeters of mercury, which makes them really thin, really thin. And they don't need to be that hard in order to remember we said 64% of your blood is found where? In the veins at any time. While in your pulmonary circuit, 64% of the blood is found in the veins and 9% is found in the pulmonary circuit, and 84% of the blood is found in the systemic circuit, because that is where the blood is being consumed the most. 15% of the blood is found in the arteries. So 15% of the blood is found in the arteries, and the pulmonary circulation only has 9% of blood. Systemic circulation only has 84% of blood. But holistically, the heart has only 7% of the blood found in it. 5% of the blood is found in the capillaries, while the veins have the highest amount of blood because they are for capacitance, for survival. Postcapillary venules, these are the veins that are right at the end of the capillary. These are these ones. Postcapillary venule, right here. These are the postcapillary venules that are receiving blood immediately after the capillary. So most leukocytes immigrate from the bloodstream through the venule walls. The muscular venules are up to 1 millimeter in diameter, and 1 or 2 layers of the smooth muscle are found in the tunica media. The median veins are up to 10 millimeters in diameter, and there is a thin tunica media and thick tunica externa. The venous sinuses, these are veins with especially thin walls, large lumens, and no smooth muscles. The dural venous sinus and the coronary sinus of the heart, they are not capable of vasomotor responses. There are large veins that have a diameter that could be larger than 10 millimeters. And these are some smooth muscles in the three, they have some smooth muscle in all three tunics. And an example of these large veins are the ones that are about to be in contact with the heart. These are your vena cavas, your pulmonary veins, internal jugular vein, and the renal veins. Varicose veins, we discussed that. Varicose veins, these are blood pools in the lower legs of the people who stand for long periods of time. And there's a backflow, and we said that hemorrhoids are varicose veins of the anal canal. Circulatory routes, we discussed that from the pump, you have the arteries, arterioles, capillaries, venules, and lastly, you have the veins. Okay, that's very important to know also. Circulatory route. Sometimes you take the subway, you go to one big station, Grand Central, you take one subway, you go home. Sometimes you take two big stations, Grand Central, then Grand Concourse, then your station. Sometimes you don't even need to take a grand station. You need to take two little subway that's going to get you to another street. You never have to stop at a central station. So the central station is your capillary. Look at this route. Sometimes you can have one station. That's an example of a simple pathway, and it has one only capillary bed. Sometimes two grand stations, Grand Central, Grand Concourse, and that is called a portal system. A portal system is when you travel through not one capillary, but two consecutive capillaries before you go back to the heart. So if you went through one and back to the heart, then through another one, that doesn't count as a portal system. You have to go through two consecutive, Grand Concourse, then Grand Central, then back into your station. Then we're going to learn about where you find a simple circulation, where you find a portal circulation. Remember in the endorphin system, the hypophysiological portal system? Yeah, it's a portal system. You go through two circulations before you go to the heart. In the liver, you have the liver hepatic portal system. It's another portal system. Sometimes you fuse with one another without having to go to any grand station. Why is that useful? That's in the palm and the fingers. Because in the palms and the fingers, you don't want blood going to the corners of your palms because it's very cold outside. Heat is going to go from an area of a high heat concentration to an area of a low heat concentration. When it's snowing outside, your heat in your body is going to leak through your tip toes and your fingers. That's why we're going to have this shunt here. So they're going to fuse into one another and make a U-turn and go back before they reach the tips. That's why you end up with a frostbite. End up with a frostbite because blood is not reaching all these ends, these tips. We also going to have venous. So, and we actually, this is called anastomosis. Anastomosis. Anastomosis is when you have a fusion, convergence, when you have blood vessels fusing and converging into one another for a purpose. Arteries, they fuse with one another to conserve heat, so that heat doesn't go from an area of a high heat concentration to an area of low heat concentration. And the veins are going to be able to make a route. That's why they are very helpful to drain the blood through alternative routes. Okay, so if one vein is occluded, another alternative venous route is gonna shunt blood back into the circulation. This may be probably the first time I had a water bottle in a year because I drink soda all the time. Very bad. Yeah. You guys are inspiring me with your water bottles and everything, so I'm developing. Because you guys have water bottles and you have water stuff.
I really like soda. Like sometimes it's spicy, I think it is. I don't like carbonation, so I never really drink it.
Yeah, carbonation is bad. Yeah, you're right. I repented. Okay, so the portal system, we discussed that where we find it in the hypophyseal portal system. And that's the hepatic. You see in the hepatic circulation, you have a portal vein that's right here. And in the hepatic portal circulation, you're going to travel from the intestine to the digestive system, digestive tract, and back into the liver. It's the stomach and the intestine, and then this is the liver. The anastomosis, we said, is a fusion or convergence point between two vessels. Fusion or convergence point between two vessels. And anastomosis is when the artery flows directly bypassing the capillaries. The venous anastomosis is the most common, and that's where one vein is going to empty directly into another. And the reason for vein blockage is less serious than arterial blockage. We said that there's always an alternative route for venous drainage if one is occluded. That's why we have a lot of veins here, like here. So if one is occluded, the other one is gonna allow for drainage. Okay. Arteries merge, like in the coronary circulation, the anterior intervertebral artery and the posterior intervertebral artery of the heart. So the blood supply to a tissue can be expressed in terms of flow and perfusion. So in the blood flow, the amount of blood flowing through an organ, tissue, or blood vessel in a given time. So perfusion is the flow per given volume or mass of a tissue in a given time. So at rest, the total flow is quite constant and is equal to the cardiac output. So important for the delivery of the nutrients and oxygen and removal of the metabolic waste. Okay, so now we discussed this very important concept. That's the greater the pressure difference between 2 points, the greater the flow, and the greater the resistance, the less the flow. Remember when we drew that between 2 points, A and B, the higher the pressure between A and B, the more flow there will be. But if there is a resistance, if there's a bumpy road, if you have two roads, path A, path B. Path A is very flat road. Path B has a lot of bumps on it. Which one is going to give you a lot of resistance and is going to make your time arrival going to be slower? So the more the resistance, the less the flow. The more the pressure, the higher the flow. And we're going to see that this is also related to the radius. So the bigger the radius, the less the resistance. The longer the blood vessel, the more the resistance. The more thick, remember we said when somebody smokes a cigarette, what happens to their blood viscosity? It's going to increase. So what's going to happen to the blood resistance? It's going to be higher. What's going to be happening to the blood pressure? Going to increase. Very good. So we said that the flow is going to increase or decrease when we increase diameter. When we increase the diameter, will the blood flow increase or decrease? It's going to flow more. Excellent. It's going to increase by actually 4 times. 4 times, the order of 4 magnitude. So R radius to the power of 4. The flow rate is proportional to the radius of the blood vessel to the power of 4. So the blood pressure, the force that the force that the blood exerts against a vessel wall. It is measured at the brachial artery, and we collapse the artery. We make 2 points. A point above the cuff that has high pressure, and a point below the cuff that has the lowest pressure. And we're gonna look at the systolic pressure, that's the peak arterial pressure taken during the contraction. And then diastolic pressure, that's the peak pressure, that's minimum, the nadir, or the minimum pressure when the blood, when the heart has completely relaxed, when the heart has relaxed. The pulse pressure is the difference between systolic and diastolic pressure. You need to know the formula for mean arterial pressure. The mean arterial pressure equals diastolic pressure plus the pulse pressure divided by 3. What's the pulse pressure? It's the difference between systolic and diastolic pressure. You get ready to calculate that. So the mean arterial pressure equals diastolic pressure plus pulse pressure. Pulse pressure is the difference between systolic and diastolic divided by 3. Hypertension is when resting, remember, resting blood pressure, above 140/90. So if somebody is coming to the doctor's office and you as a nurse, you take a blood pressure and when you find 145/95, doesn't mean hypertension, because they were running to make the appointment because they were lazy and they were trying to make the appointment and they weren't there in time, or because there was some traffic accident, or because there was some problem. They trying to make the appointment and not be late, so they ran, they got there. So that's not resting. You need to make them calm down for like 15 minutes and relax, then take the blood pressure. If it's still high, that's hypertension. And we said for the elderly, it is normal for them to have a high blood pressure as a resting blood pressure, and that is due to the arterial sclerosis. Very good. For an elderly person, it could be up to 150/95, 150/90, 150/100. This formula, cardiac output equals heart rate multiplied by stroke volume. We discussed this formula last week, and we said diuretics, they make you pee a lot of water, deplete water from your blood volume, and that's gonna bring down the stroke volume. And then we said the calcium channel blockers and these beta blockers, what do? Calcium channel blockers, beta blockers, what do? Do they affect the stroke volume or the heart rate? They affect the heart rate and they reduce it. So that's how we end up with a lower cardiac output. What does this figure shows you? That shows you that the aorta has the highest blood pressure, followed by large arteries, small arteries, and as you go farther away from the heart, the blood pressure is going to keep dropping and dropping. We said that the blood viscosity is going to increase blood pressure. So the resistance is going to increase with the viscosity, with high blood volume. It could be because of the red blood cells increasing because somebody is smoking cigarette, and that's going to cause the blood cells to attach and clump up together. Also, that could be because blood is going to be replenished because somebody's red bone marrow is generating more red blood cells, assuming there is no oxygen in the blood. So blood viscosity is going to increase resistance. Vessel length. So if you roll a bowling ball, it's not going to roll endlessly. It's going to have to stop at some point because the path is so long So the longer the path, the farther the liquid travels through a tube, the more cumulative friction is going to encounter. It's going to ultimately lead it to stop. Lastly, the radius. We talked about that. This radius is proportional to the power of 4. So isn't that interesting? Doubling the radius is going to increase the flow by how much? 2 to the power of 4. How much is that? 16 times. So if you double the radius 2 times r, you end up with 2 to the power of 4. If you drop the radius, you drop the flow by r to the power of 4. That shows you how strong your vessel radius is in dealing with the blood pressure. That's why one of the treatments for blood pressure is to target the vasodilation and the vasoconstriction. We want to, if we want to drop the blood pressure, we increase the blood vessel diameter, and with the blood vessel diameter is going to drop. It's going to drop the blood pressure significantly. Is that clear? So from the aorta to the capillaries, the blood viscosity or the speed is going to decrease for 3 reasons. Greater distance, there's going to be more friction to reduce the speed, and the smaller radius of the arterioles and the capillary is going to offer more resistance. So from capillaries to vena cava, the velocity is going to increase again. And since the veins are larger, they create less resistance than the capillaries. There is a large amount of blood that is forced into the smaller channels, and the blood in the veins is never going to regain the velocity that it had in the large arteries. Arterioles are the most significant point of control over the peripheral resistance flow, and these are the resistance vessels. What are the resistance vessels? These are the arterioles. So now we discussed that we need to control. We discussed that we're going to need to control the blood flow. So we control the blood flow how? By vasodilation and vasoconstriction. But who's responsible for that? You have local control, meaning the tissue itself has an autoregulatory effect. Auto, by its own self, regulate blood vessel diameter, increase and decrease. Also your brain. Your brain is gonna, if your brain is lacking oxygen, it's gonna send blood to itself. You bet, it's gonna do that. It's called the medullary ischemic reflex. It doesn't want ischemia. And also hormonal control. There are hormones like HGH, natriuretic peptide, that is gonna reduce blood pressure. And you have aldosterone and angiotensin that's gonna increase blood pressure. So those are the 3 ways by which we affect our blood pressure and blood flow. So autoregulation, we said, as the ability of the tissues to regulate their own blood supply. So there's a metabolic theory of autoregulation. So if the tissue is inadequately perfused, so how does your tissue autoregulate blood flow to itself? If the tissue is exercising and there's a lot of acid and a lot of metabolic waste, do you think it's going to increase blood vessels or decrease them? I'm sorry? Increase them, yeah, because you want blood. I'm suffocating. I'm running a marathon, I'm suffocating. I have so much carbon dioxide building up. Increase blood vessel so blood can come to me. That makes a lot of sense. What about the opposite? If the tissue has enough oxygen, it doesn't have acid, then it's going to reduce blood flow to itself. That's an example of autoregulation based on the status of the tissue. So here we affect the pressure by the vessel modulation. The pressure could be changed by many things. Sometimes the pressure could be caused by a pump. Sometimes the pressure could be caused by affecting the rate of the vasodilation. So if I need blood, I secrete substance that's going to make my blood vessel diameter increase so I can shunt nutrition and blood to my own cell. I can even make more blood vessels. Like a tumor cell, you make angiogenesis, you make extra blood vessels, build extra blood vessels to nourish itself with extra blood so it can survive. That's why many tumor medications are targeting the angiogenesis, tumor angiogenesis, to prevent the tumor from making more blood vessels. Yeah, it's hydrostatic pressure because we're not dealing with solids. Here we're dealing with blood vessel increase. So we're constantly increasing blood pressure, decreasing blood pressure, decreasing blood vessel in order to gauge how much amount of blood is nourished in the tissue. Auto-regulation, the tissue itself, based on its status. Does it need more blood? It will increase blood vessel diameter. Does it need not enough blood? It doesn't need extra. Because too much of anything is bad. We don't want too much oxygen that we're going to squeeze. Yeah. So the cancerous tumor is going to be making angiogenesis. Remember the angiogenesis? That's they make the blood vessels sprouting, making new blood vessels. So the tumor wants to make new blood vessels so it can steal blood to its own cells so it can grow. You know, the tumor in the end of the day is a cell. It needs to grow. It needs blood supply. So in order to grow, in order to get this extra blood supply, it needs a conduit. It needs a blood vessel. So we will make them in order to start stealing blood from the circulation. Okay? The placenta was made as a middle ground communicator between the mom's circulation and the baby.
Then you can build, that is like the direct connection, is what I mean, like, with the whole sprouting of extra blood vessels.
That's an actual, excellent. But the placenta isn't just vessel. The placenta is a microcirculation. It's both. It's red blood, oxygenated blood arteries, and blue blood. So here you only have one type. You have extra blood coming in, but you're not making a circulation. But the placenta is making an actual microcirculation. You know what I mean? In order to nourish the baby. The baby's lung is not breathing air, it's in the amniotic sac. So now we're gonna reroute the blood from having to go to the lung of the baby, you go to the placenta. And the placenta is gonna get blood from the mom and give it back to the baby. Okay? Yes. Any questions? Any other questions? The vasoactive chemicals, these are substances secreted by the platelet, endothelial cells, perivascular tissue to stimulate vasomotor responses. Like histamine, we saw that with inflammation. That's why we take antihistamines. Antihistamines are gonna fight inflammation because histamine constrict blood vessels because we don't want to lose blood during inflammation. Because in inflammation, there is injury, there is blood leakage. So we want to cause vascular spasm. We want to constrict blood, prevent blood from flowing. Bradykinin and prostaglandins that stimulate this vasodilation. So histamine is going to cause blood rush. That's why the area with inflammation is red, because blood is rushing to the site of the injury. So we take antihistamine to stop the blood shunt to that site and reduce the blood flow there. So you're not bleeding a lot, it's not red a lot. So that's the anti-inflammation. Reactive hyperemia, that is if the blood supply is cut off, then restored. That's when you go out to the cold. When you go out to the cold, your cheeks are going to become red when you go back home. Why is that? Because when the cold hit your cheeks first, that was like a sort of hypothermia. That's a stress. So blood is going to be rerouted away, so that if the blood was coming near exposure to the cold, the heat of the blood is going to escape to the cold. You're going to have hypothermia. So blood is going to be rerouted away. But when you go back in a home where it's really warm, now blood is going to be flowing back to your cheeks, and it's going to be flowing back harder. That's going to be really, really red. That's reactive. It's going to be reactive hyperemia. Angiogenesis. We said that's the sprouting of blood vessels, the growth of new blood vessels. And that's going to occur in the uterine lining, around coronary arteries, and exercising muscle. And you see malignant tumors. The tumor is going to start to make sprouting of blood vessels. And that's controlled by several growth factors and inhibitors. So the central and autonomic nervous system also going to exert control over the blood vessel size. We said we have, now the nervous system is going to come into play. It's going to affect the blood supply. So you have the Barrett's reflex. You know the Barrett reflex? Could report what? What does the Barrett reflex report? I can't hear you. The Barrett reflex is gonna do what? Not here. I didn't hear. Reflexes? Yes, so it's gonna be a reflex for. It's gonna be a reflex to what? To high blood pressure. Remember we said last week when blood pressure is too high, we're gonna send the glossopharyngeal nerve to your brain, and then the vagus nerve is gonna lower the blood pressure. So the Barrett reflex is to lower the blood pressure. What does the chemo reflex do? So when there is a lot of acid and carbon dioxide, it's going to make you hyperventilate. What does the medullary ischemic reflex do? When your own blood is choking, when your own brain doesn't have blood, it's choking, it's going to route blood to its own self. Your brain is going to nourish its own self with more blood. Is that clear? So that's a negative feedback response to change in blood pressure. The Barrett reflex is going to govern short-term regulation of the blood. And you see that's the glossopharyngeal nerve. Okay. Let's talk about this after the break. Let's have a break till 2. We will come back, wrap up the lecture, then we will do the lab. Okay? We have about a couple. We talked about all the concepts, but now we just need to just go over them in the slides one more time, and then we will do after that we will do the lab. Let's come back at 2.
closest window? Oh.
Hello, guys. Okay, so we stopped here. We were discussing that there are three ways by which your nervous system is going to be regulating blood pressure and blood flow. And we said the first way is your baroreflex. The second way is the chemoreflex. The last way is the medullary ischemic reflex, and that's preserved in the brain itself. So when the brain itself is choking, when the brain itself doesn't have sufficient oxygen to operate, that one is going to kick in. The medullary ischemic reflex is going to start to shunt blood to its own self to nourish the brain itself. While the baroreflex, we talked about that. That's really important. And I told you, you have to know it in detail. We said that the baroreflex starts with receptors sensing what? Sensing what kind of change? Well, yeah, what happened to the blood pressure? Increase and decrease? Increase. Yeah, increase. Then, which nerve is gonna go where? Telling that there is an increase in the blood pressure. Excellent. The glossopharyngeal nerve is gonna go where? To the brain, and then the brain is gonna send that correcting output to drop the blood pressure through which nerve? Excellent, the vagus nerve, and then the vagus nerve is gonna make the heart rate go up and down. Down. Good. Chemoreflex does what? Chemoreflex. No, you can't nod your head because I said that 10 times. Okay, so credit is not just by doing good on the exam that I give you from beforehand. You have to pay attention in class, and I'm gonna ask you a question, and you don't answer it, it's gonna drop your attendance score. Okay, you're not here by your body and your mind also. I mentioned chemoreflex many times. How does the chemoreflex work? Yeah. Yeah, say it again. You do that? Can you please say that, Darian?
She was sort of like after to make it like whenever this change in school, for example, pH, whenever it's so high, we will start let's say hyperventilating without CO2.
Excellent. But when the pH is too high, when the pH is too high, when the pH is too high or too low?
Too low.
Too low. When the acidosis is high,
Right.
when the carbon dioxide is high, when the pH is low, then we hyperventilate. And vice versa. When the carbon dioxide is low and the pH is high, we hypoventilate. So doing both, we hyperventilate when it's necessary, and we hypoventilate when it's necessary. That's chemoreflex. So these chemoreflex, they don't detect distension and pressure. They taste it. It's salty. It's too carbon dioxide, too acidic, too basic, and then they feed back. And the last one we said is the medullary ischemic reflex. When does that kick in? Yes, Vandella, when does that kick in? Can you say it again, please? Yeah, excellent. Can you say it audible so she can hear you? Did you hear that? When the brain is not getting enough blood to its own self, it's gonna reroute some blood to
So is that the medullary ischemic receptors?
reflex. So the medullary ischemic receptor, they're gonna detect that there is a.
Also the receptors, because I know the receptors, chemoreceptors, there's also medullary ischemic receptors. No?
These are receptors that make the reflex, receptors that make the reflex, receptors that make the reflex. So we're describing the reflex.
Okay.
So the receptors are part of the reflex arc. Remember, the reflex arc is comprised of a receptor, a nerve that carries the input, a center, integrated center, 911 center, then an output, then an effector. So the receptor is part of a circle. We're not talking about the receptor only. We're talking about the reflex, the whole reflex. Okay? So if you look here, if the blood pressure is elevated, the beta receptors, you see where my mouse is, the beta receptors are going to increase the firing, and that's going to go to the cardio-inhibitory center, and that's going to inhibit I'm going to depress the blood pressure by increasing the vagus, and you know the vagus is a depressor. Reduced heart rate. So that's gonna drop the heart rate. And also the vasomotor center is inhibited. So that's gonna reduce sympathetic tone. So you know the sympathetic tone is gonna increase fight or flight. You wanna survive. Blood pressure up, heart rate up, contractility up. You're running for your life. So that's sympathetic, fight or flight. That beta reflex is gonna depress this vasomotor center and reduce the sympathetic tone. The chemoreflex, that's an autonomic response to changes in the blood chemistry, especially the pH and concentrations of oxygen and CO2. Chemoreceptors are called aortic bodies and carotid bodies. They're located in the aortic arch, subclavian arteries, and external carotid arteries. They adjust the respiration to changes in the blood chemistry, and they are responsible for the vasomotion. And we discussed how this happens in alkalosis and in acidosis. The medullary ischemic reflex. What is that? That's the autonomic response to a drop in perfusion of the brain itself. So the medulla oblongata monitors its own blood supply with receptors, activates corrective reflexes when it senses ischemia. Cardiac and vasomotor centers send sympathetic signals to heart and blood vessels. Other brain centers can affect the vasomotor center. Stress, anger, arousal can also increase blood pressure. Hormonal control. Hormones influence blood pressure. So some through their vasoactive effects and some by regulating the water balance. Angiotensin 2 is a potent vasoconstrictor. It raises the blood pressure. So these are the hormones. Remember we said that hormones play an important role in regulating the blood pressure. We talked about atrionatriuretic peptide, AMP. So you need to know angiotensin 2 is a potent vasoconstrictor. It's going to raise the blood pressure. All that one you really need to know. I'm going to talk about this in more detail next section. And that's going to be known as the renin angiotensin aldosterone axis. I think you already did that in the endocrine system. renin, angiotensin, aldosterone axis. So the endocrine system was part of AMP1, right? Part of AMP1. So that's the system responsible for regulating a drop of blood pressure, and then renin is secreted by the kidney, then renin converts angiotensin, nogen into angiotensin 1, then angiotensin 1 goes into the lung, and then the angiotensin converting enzyme ACE is going to convert angiotensin 1 into angiotensin 2, then angiotensin 2 is going to cause the vasoconstriction, increased blood pressure. Aldosterone is going to uptake sodium and water as distal convoluted tubules. Who taught you AMP1? Mulai. Where is that? Here? Mulai? Mulai. You guys. You take it here, raise your hand if you took it here. Who was your professor who taught you here? Substitute? You don't know your teacher? You don't know who your professor is? Yeah, he was new. You don't even know him? He told you the course, you don't know him? Okay, no problem. Thank you, no problem. And then you have AMP, atrial natriuretic peptide. So atrial natriuretic peptide is the opposite of angiotensin 2. So angiotensin 2 is gonna restore blood pressure after it dropped, while AMP is the opposite. It's gonna repair blood pressure after it has increased. So atrial natriuretic peptide is going to increase sodium excretion. And you know who follows sodium? If sodium is going one direction, who's right behind it? Water. So it secretes sodium, it secretes water, blood volume is going to drop, blood pressure is going to. Aldosterone reuptake sodium, water behind it, blood volume increase, blood pressure increase. Antidiuretic hormone promotes water retention and raises blood pressure. So pathologically, there is high concentrations, also a vasoconstrictor known as vasopressin. Epinephrine and norepinephrine effects. These are they are found mostly on the blood vessels. They bind to alpha adrenergic receptors. And once they bind to the alpha adrenergic receptor, these epinephrine and norepinephrine, they're going to cause vasoconstriction. Okay. And we discussed this, that if you look here, you will see that for these people who are exercising, the blood vessels going to the muscle are vasodilated, blood is running to the muscle, while in their intestine there is no blood that's going to, because they're not digesting it. But this person on an armchair, that person, no blood, the blood that's going to the skeletal muscle is vasoconstricted because we don't need that much, while the one that the blood vessels that are heading to the intestine are vasodilated because he's eating and you need to digest. Are we clear? So we have to be able to manage which amount of blood goes where. So at rest, you see that's how the blood is divided. But at moderate exercise, you see most of the blood goes to the muscular system. Okay, now for the capillaries, we alluded to that. In capillaries, we talked about diffusion. So we talked about toxics diffusing to area of lower concentration. Transcytosis, remember the figure? where we showed the bubbles go either from the inside of the endothelium through the cytoplasm to the outside, or endocytose from the outside through the cytoplasm into the inside of the cell. That's what I was talking about. Remember that. Transcytosis, the bubble is going to go from the inside through the endothelium and then opening to the outside, and vice versa, from the outside going through the cytoplasm to the inside. That's known as transcytosis. Or moving through the pores, that's filtration, diffusion through the filtration pores, and these are interendothelial gaps. And then you can also have diffusion through the endothelial cells. Okay, filtration, we discussed that. So this is what I was saying earlier. This is bluish side. That's the venous circulation. That's the reddish side. That's the arterial circulation. So you're gonna come in, there is a net filtration, hydrostatic pressure. So you're squeezing the blood that's gonna go into the tissue. Once you go to the vein, there is a reabsorption pressure where 20 is going to move in and 13 is going to move out, but the difference, there is a net difference of all the toxins moving out. So at the venous end, there is a filtration arrow pointing to the tissue. But at the venous end, there is an arrow pointing away from the tissue into the venous circulation. We're heading back. That clear? So this is the hydrostatic pressure powering this movement, and this is the osmotic pressure. What's the oncotic pressure? Oncotic pressure is the difference between the osmotic pressure in the blood vessel and the osmotic pressure in the tissue. That's the oncotic pressure. So the oncotic pressure is going to favor leakage out from the tissue or leakage into the tissue. The oncotic pressure, is it going to cause fluid to leak out from the tissue into the blood or out from the blood into the tissue? The arrow is right here. So the arrow is right here. So that's the tissue, that's the blood vessel. The arrow is already pointing from the tissue to the blood vessel. Right? You see it. The arrow only points away from into the tissue here at this side, because we're trying to go to the tissue. We're trying to give the tissue oxygen. We're trying to give the tissue nutrient. We're trying to give the tissue hormone. So the arrow is going to point here thanks to the hydrostatic pressure. But at the other side, where we're trying to become blue and go back, the arrow is pointing out. Because the osmotic gradient is going to favor a colloid pressure that's going to go from the tissue to the the waste, the solution, the dilution of the waste, of the toxics and metabolic waste and all of that. It's going to favor an oncotic pressure that's going to be on the side of the venules here, going from the tissue into the venules. Clear? Okay, so you need to know the movement. So blood is going to come in, is going to unload oxygen because the hydrostatic pressure is forcing it. And then when it gets here to this side, is going to reabsorb all the waste because the colloid pressure, there is so much waste here. So here we move by hydrostatic pressure, and here we move by colloid pressure, osmotic pressure.
It's the same blood flow.
Yeah, the same circulation, one circulation, the same circulation. Are we clear? Any questions? Capillaries usually reabsorb most of the fluid. They filter with certain exceptions. So the kidney capillaries and the glomeruli do not reabsorb. And the alveolar capillaries absorb completely to keep fluid out of the air spaces. Okay. We discussed edema, and we said edema is when there is more filtration and less reabsorption. So fluid is going out to the tissue, but is lagging behind. Remember the issue I was talking about earlier? Remember the issue I was saying earlier, that at the venial end, you rely on oncotic pressure and some lag behind, and the lymphatic system restore it. But if you look here, you see that why do people have edema? It's because there is a difference in osmotic gradient. There is increased capillary filtration, so we are dumping fluid, but we're not reabsorbing it back at the venial side. Reduced capillary absorption. So we have the same rate of filtration, but a completely deteriorated failure in reabsorption. And obstructed lymphatic draining. So the lymphatic system that's going to go green parallel to our venous system is not working. So that's going to lead to edema. These are the three causes that's going to give you edema. If somebody has edema, it's one of these causes. Also, tissue necrosis and pulmonary edema, cerebral edema, these are different kinds of edemas that we are dealing with. Okay, the last thing is to talk about, these are the skeletal muscle pumps. These skeletal muscle pumps, they work by, when they are relaxed, they allow for the blood to move downward. But when they contract, they pressure blood to move upward. So the skeletal muscle is a pump that helps return blood back to the right heart, the venous circulation. There's another pump, the thoracic pump. So the venous return, also when you exercise, you increase the venous return to the right heart. So circulatory shock is any state in which cardiac output is insufficient. And that could be because of cardiogenic shock, meaning the heart is not pumping enough due to some arrhythmia or some derangement in the electrical activity of the heart, due to low venous return because the cardiac output is not sufficient. And there's three principal forms of left ventricular return shock. Hypovolemic shock is because when we don't have enough water in our blood, trauma, burn, we have lost a lot of water through burn, through hemorrhage. I can't believe they didn't add that one here. Hemorrhage, like a gunshot wound, stabbing, you lose blood endlessly. Obstructed venous return shock, when the tumor or aneurysm compress the vein. And venous pooling, when there's a vascular shock and when there's long periods of standing, sitting, or widespread vasodilation, the blood is not circulating because it's pooling. Neurogenic shock, that's a problem of a severing of the spinal cord of some damage to the brain stem that's not going to allow the blood vessels to relax, because remember, you have a plexus, a nerve plexus in your spinal cord and the brain that's responsible for the vasodilation of your blood vessels. So due to the damage, you're going to have neurogenic shock. Septic shock is when you have a bacterial infection, and when there's a bacterial infection, your blood vessels are vasodilating because they're trying to get blood to move quickly. And what happens when you vasodilate? What happens to the blood pressure when you vasodilate endlessly? It goes up or down? It goes down, because you vasodilate, you drop the resistance. So the blood pressure is gonna go down. The blood pressure is gonna increase when you vasoconstrict. If you have a water coming out the water hose and you compress the tip, isn't the water gonna gush out harder? So that's the blood pressure increase when you vasoconstrict. But here, because of inflammation and ongoing shock, infection that's going on and on, 2 days, 3 days, a week, 2 weeks, 3 weeks. So your body is going through an endless state of vasodilation that's gonna drop the blood pressure. That's a septic shock. So blood pressure drop due to an infection. Anaphylactic shock, same thing, but not because of infection, but because of some severe immune reaction that's going to increase, you see, generalized vasodilation. Okay. There are special circulatory routes in the brain, and we talked about the ischemic attack. That's when there is a loss of oxygen supply to the brain, and severe case would lead to cerebrovascular accident. Now this is just going to show us the main blood vessels. So this is just going to require you just going over your main. So that is showing you the anatomy of the pulmonary circuit. That is the left pulmonary artery. That's the right pulmonary artery. And you see there's a superior lobar artery, middle lobar artery, and inferior lobar artery. On the left side, you have a superior lobar artery, left pulmonary artery, and inferior lobar artery. There is no middle lobar artery on the left side. Why? Because the left lung has 2 lobes. You see one, and that's you see this oblique fissure. So 2 lungs on top of each other. But here you have 3. You have a horizontal fissure here, 1, then a 2 here. That's why you have a middle lobar artery on the right side. It's at the alveoli, and this is the pulmonary artery from the right ventricle. And this is the pulmonary vein that's heading to the left atrium. That shows you the major systemic arteries. And we see here the aorta, subclavian, and the vertebral arteries, and the internal thoracic. So that shows you the major systemic arteries. And this is the ascending aorta, the aortic arch. So that shows you the aortic arch, and you have 3 branches. That's the brachiocephalic trunk, which will give you the right subclavian, right common carotid. In the middle, you have the left common carotid, and then you have the left subclavian. So don't go crazy with all of these vessels. You just need to know the very big ones. The ascending, the aorta, the aortic arch, those 3 branches, and what comes out of each branch. So the ones that are very big, not the very tiny ones. Okay? And that shows you here the circle of Willis, and these are the major systemic veins. So with every artery, you need a draining vein that's going to remove the deoxygenation and return it back to the heart. That's the head and neck. It's going to show you the external jugular vein, the vertebral vein, and the... So just for those, rely on the questions that are on the lab figures, and that's all that you're going to be responsible of. Any questions? Does anybody have any question? So we talked about ascites, and that is an accumulation of fluid due to an imbalance that leads water to move from where to where? From blood into the tissue. Yeah, from the blood into the tissue. Okay, lastly, we have hypertension, known as the silent killer. It is the most common cardiovascular disease. And primary hypertension is caused by a lifestyle. Secondary hypertension, you had some primary disease that led to the secondary hypertension. So you don't have hypertension, but you had some disease that caused the hypertension. Like you have kidney failure and you're losing all the proteins. And when you're losing all the proteins, it's gonna cause an osmotic balance, and that's gonna disrupt your blood pressure equilibrium. That's gonna increase the blood pressure, as well as atherosclerosis, hyperthyroidism, and Cushing syndrome.